Amma, Dr. Pranitha Reddy, good evening, Amma.
Hello, sir.
Good evening, Amma. It is a very good topic. Actually, all residents should join. Next week, పెట్టుకుందాం అమ్మా.
Why, sir?
Hello.
Hello, why, sir?
హలో.
Hello, yes, sir.
మీ వాడు యాక్చువల్ ఇవాళ పొద్దునే పోస్ట్ చేసింది అందరి గ్రూప్ లో. మేట్ బి ద మెసేజ్ మే నాట్ హావ్ రీచ్ టు ద మెజారిటీ ఆఫ్ ద పర్సన్స్.
Oh,
Yeah.
we
Actually, 2-3
decided
days before.
unexpectedly in last minute, sir.
Last minute only posted actual గా.
This will be anyways
Shall we
posted in
continue,
the
Amma?
YouTube, sir.
Shall we continue?
Yes, sir, yes.
And there may be several participants in the YouTube channel.
Yes, sir.
Okay,
I
Amma.
will go. Yes, sir.
Yeah, it's good topic. Thank you. Thank you.
So, hello everyone, I'm Dr. Pranitha, pediatrician and a neonatologist from KIMS. Today we are going to discuss about NRP program. So NRP is undoubtedly one of the most important practical topic for any pediatrician, neonatologist and gynecologist as well as for the nursing staff. I'll discuss the topic under the following headings. So the focus of neonatal resuscitation is effective ventilation of the baby's lungs. So this is the cornerstone of NRP. So we'll just briefly discuss about the transition. When the baby is in mother's tummy, lungs are filled with fluid and the placenta is the main part of circulation. The blood from the RA is mostly shunted to the left atrium and only 10% of blood goes to the lungs. So after birth, when baby cries, the PVR falls and lungs are replaced by water with fluid. The pulmonary vessels become dilated. The pulmonary pressures decreases. And once the umbilical cord is clamped, the systemic vascular resistance rises. As the PO2 levels increase, the foramen ovale closes and slowly the ductus arteriosus also closes. Now the lungs become the major part of oxygen exchange and the placental exchange is removed. The pulmonary pressures also slowly come down. So if there is any problem in any of this transition, it usually results in the baby having some problems like difficulty with breathing, apnea, tachypnea, bradycardia, tachycardia, hypotonia, pallor, cyanosis, hypotension, and hypoxemia. So this is the basic NRP chart. We'll go through this step by step. So whenever we get to know that there is a delivery, first we need to do the pre-resuscitation team briefing. We need to assess the risk factors, assign a team leader, anticipate the potential complication, and identify who will document events, who will take care of what part of the NRP protocol, and whether the supplies are available, and whom to call if there is a need for additional help. So the main reason for many potentially preventable neonatal mortalities is poor communication between the team members and lack of teamwork. Closed-loop communication ensures successful coordination. So before delivery, we need to ask our ops colleague regarding 4 important questions. One, the most important being the gestational age, followed by any risk factors, maternal or fetal risk factors, liquor, whether there is any Meconium-stained liquor, and the umbilical cord management. So these are all the risk factors which increase the likelihood of neonatal resuscitation. The most important being the maturity of baby. Any baby less than 37 weeks or more than 41 weeks is more prone to require resuscitation. And there are certain other maternal risk factors like PIH, maternal hypertension, polyhydramnios, oligohydramnios, and certain fetal risk factors like fetal anemia, hydrops, fetal malformations, macrosomia, IUGR, and lack of prenatal care is also a risk factor. And there are certain other intrapartum risk factors like the need for emergency LSCS itself increases the likelihood of resuscitation, along with forceps delivery or vacuum-assisted delivery, breech presentation, category 2 or bradycardia, fetal bradycardia, the requirement of maternal general anesthesia or magnesium therapy, which will depress the baby at birth, placental abruption or any other form of intravaginal bleeding, chorioamnitis, opioids administered to mother within 4 hours of delivery, shoulder dystocia, meconium-stained amniotic fluid, prolapsed umbilical cord. So why is this important to know? Because the more the risk factors, the more is the likelihood of neonatal resuscitation. But also it is important to remember that some newborns without any apparent risk factors may still require extensive resuscitation. And hence, for every delivery, we need to prepare to the maximum. So every birth should be attended by at least one qualified individual. And if there are any risk factors, at least 2 qualified people. And every hospital should have a dedicated newborn resuscitation corner. And before delivery, we should always do a checklist for all the equipments. So this is a must to avoid panic during the resuscitation process. So first one is temperature. So for temperature maintenance, we need the warmer, which is switched on in manual mode with 100% heat output, warm towels or blankets, temperature sensor, plastic bag or wrap for preterm babies, thermal mattress, and incubator, again for premature babies. For clearing of airway, we need a bulb syringe with suction catheters of various sizes, wall mounted to the suction tube, and pressures should be around 100 mm. It should be set before the delivery itself. And for ventilation, we need a flow meter set to 10 liters with oxygen blender, PPV device, various size masks, laryngoscopes, OG tubes of various sizes, and cardiac monitor. For oxygenation, we need equipment to give free flow oxygen along with the pulse oximeter. And for intubation, we need laryngoscopes of various sizes, ET tubes of various sizes, and things for fixation of the ET tubes along with medications like epinephrine and normal saline. So epinephrine should be diluted before itself, and equipment for UVC placement should also be available. So let's go through the initial steps of resuscitation. So in the first part of resuscitation, we need to ask 3 main questions when a baby is born. Is the baby a term baby? How is the tone? How is the breathing? Is the baby crying? So the first picture shows a well baby who is pink, crying well, tone is normal, and baby is breathing. So for this baby, we can shift the baby directly onto the mother's chest for skin-to-skin contact. And we can do the rest of the warming and drying over the mother itself, do delayed cord clamping. So regarding umbilical cord management, this is the latest update, 2023 update, which recommends that for preterm babies who do not require resuscitation, it is reasonable to delay cord clamping for longer than 30 seconds. And for term babies who do not require resuscitation, also we can delay cord clamping for longer than 30 seconds. So for baby who require resuscitation, both term as well as preterm, there is insufficient evidence to recommend early cord clamping versus delayed cord clamping. And in babies born less than 28 weeks, cord milking is not recommended as it increases the risk of IVH. So for term and preterm, late preterm babies, more than 34 weeks who do not require resuscitation, delayed cord clamping can be done for 30 seconds, which is beneficial when compared to early cord clamping. And for non-vigorous term and late preterm babies, intact cord milking may be reasonable when compared to early cord clamping. That is, if the baby is non-vigorous. So after the initial steps, in the initial steps, if the baby is instead not having good tone, not breathing, not having proper respiration, is looking blue, then we shift the baby to the warmer and carry on with the initial steps of newborn care, which is reframed a little in the latest one. So first we shift the baby to the warmer. In the warmer, which is already put on in manual mode with 100% heater output. Then we change it to servo mode, set temperature around 36.5 to 37.5. We need to avoid both hypothermia as well as overheating because both of them increase the risk of mortality. And always, if you are admitting the baby to NICU, note the admission temperatures as it also correlates with the mortality risk. And after keeping the baby under the warmer, we need to dry the baby, which is not necessary for a premature baby, which is accompanied along with the stimulation of the back, trunk, and extremities. So after that, we need to go ahead with the positioning. So once the warming, drying, stimulating is done, we need to position the baby. So the second picture is the correct position. We should avoid both hyperextension as well as hyperflexion. The baby should be in a sniffing dog position with eyes facing towards the roof and avoid hyperextension and flexion. And then if there is any secretions, we need to clear the secretions. If the baby, especially if the baby is not breathing, is gasping, or we see any visible secretions, if there is meconium-stained fluid, or whenever we are starting PPV also, it is better to clear secretions. So remember M before N, do clear the secretions from the mouth before the nose. Do not suction vigorously or deeply as it can inhibit the breathing. And the suctioning can be done either with a bulb syringe or with the suction tube. So usually once the baby shifted to the warmer, we connect to the pulse oximetry, but the other indications are whenever resuscitation is anticipated, when there is visible perception of central cyanosis, whenever we are giving supplemental oxygen, or when PPV is required, we need to connect pulse oximetry because visual assessment of cyanosis is not a reliable indicator of oxygen saturation. We should also have this chart with the target oxygen saturation. So at birth, the saturation levels are only 60 to 65%, and they increase by 5% every minute. And only by 10 minutes, they reach 85 to 95%. And the initial oxygen concentration for late preterm baby or term babies more than 35 weeks is 21% oxygen, that is room air. And babies less than 35 weeks of gestational age is 21 to 30%. So how do you assess the response to the stimulation we are giving? First, the heart rate improves, followed by respiration, and tone is the last. So tone abnormalities are the last to appear and the last to disappear. And for the assessment of heart rate, the cardiac monitor is preferred method, followed by stethoscope. So we can count for 6 seconds, multiply with 10. And then we can also do by pulse oximetry. Umbilical pulsations are less reliable. So when the target saturations are below the expected normal, we give supplemental oxygen, which can be given by a flow inflating bag, a TP's resuscitator, or a tail of a self-inflating bag with reservoir. So now we have a baby. The baby is apneic, baby is not breathing, baby is looking cyanosed. So in this case, we go ahead with PPV. But in case if the baby has only labored breathing or persistently low saturations, then we go ahead with the CPAP. So we are not going to discuss about CPAP here. So when do we give positive pressure ventilation? So whenever baby is apneic, not breathing, baby is gasping, or the heart rate is less than 100 in spite of the CPAP. So these are the indications, and whenever indicated, PPV should be started within the first 1 minute of birth. So all the other steps should have been done within the 1 minute itself. And we can give PPV by either the self-inflating bag, the flow inflating bag, and the TP's resuscitator. So this is the bag and mask. Always check whether the bag and mask is properly functioning, whether the pop-up valve is functioning properly before the resuscitation process itself. And this is the flow inflating bag. This is the TP's resuscitator. So in the TP's resuscitator, we usually set the flow meter to 10 liters, and the PIP can be increased with the right knob by going towards the right side. Usually we'll set the pressures at 20 to 25, and we'll slowly increase in the steps of 5 to 10 mm of Hg. So for term babies up to a maximum of 40, and for preterm babies up to a maximum of 30. And PEEP is set by adjusting this valve. So PEEP is usually set around 5 mm to 6 mm, and that is checked by placing the mask on our hands. So all this has to be done before the baby is delivered and not after the baby comes. So previously for PIP, the NRP 2020 did not recommend anything, but in the latest 2023 update, it is recommended that it is better to use a TP's resuscitator instead of a self-inflating bag with or without a PEEP for administering positive pressure ventilation to newborn infants, especially for preterm infants. So when you are delivering the PIP, you stand at the head of the bed and then place the baby in the sniffing position. The mask has to be correct size. It has to be covering the nose and mouth. It shouldn't be neither too small or too large. We can either hold the mask by one hand technique using the easy clamp technique. So the first two fingers are placed on the mask and the other three fingers are used to give the jaw thrust. And in case if that is not effective, we can use this two-hand technique with jaw thrust, in which the first two fingers of both the hands are used to stabilize the mask and the other fingers are used to stabilize the jaw, giving a mild jaw thrust. So for PPV, we usually give at the rate of 40 to 60 per minute. So we say out loud, breathe 2, 3, breathe 2, 3. So when we say breathe, it is squeezed, the bag and mask is squeezed, and then it is released so that it gets refilled. So after starting PPV, we need to measure the heart rate after 15 seconds. So after 15 seconds, if the heart rate is increasing, then we will continue PPV. We'll again assess the heart rate after 15 seconds. So after 15 seconds, if the heart rate is not increasing, but the chest is moving, which means our ventilation is correct, but the baby is still not improving, then we can take another 15 seconds of time to see if the baby improves. If the chest is not moving, as well as the heart rate is also not improving, which means our ventilation is not correct. In that case, we need to go ahead with the ventilation corrective steps. So this is the famous MR-SOPA acronym, which stands for M is for mask adjustment. So we usually start with 2 steps each time, give 5 breaths, then go to the next step. So first one is mask adjustment. We'll reapply the mask. We may consider using the 2 hands technique, lift the jaw, then reposition the head, use a slightly neutral or slightly extended position. After doing this, we again give 5 breaths. We check for the chest movement. And if there is no chest movement, then go to the next steps. So the next steps is suctioning the mouth and nose with either a bulb syringe or a suction catheter and gently open the mouth. Then again give 5 breaths and assess the chest movement. If there is no chest movement, the next step is increasing pressure. So we are going to increase in the steps of 5 to 10 centimeters up to a maximum of 40 for term and 30 for preterm. Then again we give 5 breaths and we assess the chest movement. And this time we go ahead with the alternate airway. So once we give the proper PPV, which is moving the chest, again we assess the heart rate. But this time, this is after 30 seconds. So if the heart rate is above 100, which means the baby is improving, then we go ahead with continuing the PPV at the rate of 40 to 60 per minute till the baby has spontaneous efforts. But in case if the heart rate is still below 100, but more than 60, then again reassess ventilation, see if the ventilation, if any other ventilation corrective steps are necessary. But if there is bradycardia less than 60, again, you reassess ventilation, you do ventilation corrective steps. But at this point, you need to consider giving chest compressions. So we'll have to intubate the baby, start on 100% FiO2 oxygen, and begin compressions. So the first part of this is alternate airways. So alternate airways, as we just thought, will be considered whenever the heart rate is below 100 or below 60. So the indications of intubation being if PPV is not causing adequate improvement in the baby, or if the PPV is being prolonged for a long time, whenever chest compressions is started, even if the ventilation seems appropriate, it is better to intubate the baby. And in CDH, we are obviously not going to give PPV, we will directly intubate the baby. In premature babies, extreme premature babies, either without any spontaneous efforts or if the baby is requiring surfactant, that is again another indication for intubation. And MSL, where the airway is obstructed by thick secretions, is another indication. So for intubation, these are all the equipment required. Again, this should all be arranged before the delivery process itself, and there shouldn't be any panic when intubation is required. So babies less than 1 kg will be intubated with a 2.5 mm tube, and 3 for 1 to 2 kgs baby, and 3.5 mm tube for greater than 2 kgs of baby. And we also need the suction catheters of appropriate size to clear the secretions. So 5 or 6 for 2.5 mm, 6 or 8 for 3 mm, and 8 for 3.5 mm. And for the depth of insertion, we usually calculate with the nasotracheal length and add 1. So that can be quickly done with the ET tube itself or with the tape. It is better to have these charts also in the resuscitation corner. So at the intubation process, so this is the epiglottis, this is the vocal cords. So we need to go through the vocal cords and we need to insert it at least at T2 to T4 level above the carina. So even if you are a left-handed or right-handed person, it is better to, we need to intubate with the, sorry, we need to carry the laryngoscope with the left hand. And the process needs to be completed within 30 seconds. So the baby's position during the intubation, again, it shouldn't be either too extended or it shouldn't be too flexed, because in the sniffing dog position itself, the airway is going to be straight. So some problems we can encounter during the process of intubation. Here, the blade is not gone too far. So we are seeing only the tongue. So in this case, we need to advance further. But in case if the blade is small, then we need to replace with a bigger blade. In this scenario, the laryngoscope is towards one side. So the glottis is only appearing half. In this case, we need to get the laryngoscope to the midline and then advance the ET tube. So in this scenario, the blade has gone too deep and hence the posterior pharynx and the esophagus are visible. So in that case, you need to retract slightly a bit and then glottis will be visible. So how do you confirm position, whether the ET is in the proper position or not? So detecting exhaled CO2 and rapidly rising heart rate are the most important ones. Along with it, we also see improvement in the heart rate, breath sounds in the lungs, absent of breath sounds in the stomach, mist in the ET tube, or all the other indicators. So this is the CO2 detector, colorimetric CO2 detector. Normally it is purple, but when exposed to CO2, it becomes yellow in color. There can be certain false negatives. That is, the tube is in the right place, but still the ETCO2 is not showing color change. That is because of inadequate ventilating pressures, or there is some problem with the lungs. The lungs have either collapsed, there is pneumothorax, or there is some problem with the heart. That is, there is very low heart rate, or baby is in shock, or if the ET tube is obstructed with some secretions. There can be certain false positives, which is that the tube is not in the trachea, but there is color change, which can be seen with some medications like epinephrine surfactant or with gastric secretion contamination. Then there can be certain other scenario where you're not able to ventilate and you're not able to intubate. This is commonly seen in babies with small airway, small mandible, large tongue, or there is some congenital anomalies involving the lip, tongue, palate, or neck. In this case, we can use the LMA. So there are certain disadvantages with LMA, which is it can be a little difficult to suction the secretions. Intratracheal medications administration might be difficult. You might be requiring some higher ventilation pressures, and it might be little difficult in very small neonates. So LMA covers the glottis like a cap, and the inflated cuff creates a seal against the hypopharynx. So this is the latest update, 2023 update, where comparison is being done with the supraglottic airway with the face mask as the initial mode of administering PPV during resuscitation. So the other aim is being to determine whether the use of the LMA would increase the probability of improvement. So the population is babies born more than 34 weeks gestation receiving the PPV. So one group has LMA and the other group has face mask. And all these factors are considered. So LMA had failure to improve with the device was lesser with LMA. Endotracheal intubation rates are also lesser with LMA. Requirement of chest compressions, though not very significant, was also lesser in LMA. And the need for adrenaline administration also was lesser with LMA. Time to improve with the heart rate of more than 100 was also faster in babies used with LMA. Admission in NICU was lesser. Risks like pneumothorax was lesser. soft tissue injury was also lesser, and survival to hospital discharge was also faster. So the recommendation is being like where there is appropriate training, it is the LMA can be used in place of a face mask for babies born more than 34 weeks of gestation for receiving of intermittent PPV, but the recommendation is weak. Then the meta-analysis of 6 RCTs were done, and they found that the use of LMA decreased the probability of failure to improve and the decreased rate of intubation. The duration of PPV and the time to reach heart rate more than 100 was also shorter. So in 2021 update, LMA was not suggested as primary interface, whereas in the latest update, it is suggested that it might be reasonable to use LMA as the primary interface to administer PPV instead of a face mask for newborn infants delivered at more than 34 weeks of gestation. Okay, so now the PIP is done and intubation is done. We are going ahead with chest compressions. So when do we consider chest compressions? Whenever the heart rate is less than 60. But before starting compressions, it is better to intubate the baby, and we need to start at 100% oxygen. And at least 30 seconds of PPV that inflates the lungs also should be given. So the compressor will usually stand at the end. We usually give 90 compressions with 30 breaths, that is 120 in 1 minute. And compression ventilation rhythm is like 1 and 2 and 3 and breathe. So during the 1, 2, 3, we are going to compress. During the pause, we are going to relax. And during the breathe phase, we are going to give the PPV. So the compressions are done in the lower 1/3 of the sternum, and at least 1/3 depth should be compressed. So this is the correct method of compressing. So here the heart is getting compressed, but here the pressure is being diverted laterally. So it won't be effective. So now we prefer the thumb technique. Fingers technique is not preferred, but in case if you are using finger technique again, this is the correct method. Here again, the pressure is being dissipated towards the lateral surface. So why is two thumb method preferred? Because it gives us better control of depth. It is less tiring, as well as the generation of the blood pressures, peak systolic and coronary perfusion pressures are also better with two thumb technique. And nails do not hinder the performance, but it can be difficult if the baby is big, and in case if we want to go ahead with the UVC cannulation. So this is the recommendation. CPR is started if the heart rate after birth remains less than 60 despite adequate ventilation for at least 30 seconds. And whether we need to start 100% FiO2 or 21% FiO2 is still uncertain, but it is at this point, we usually start on 100% FiO2. So once the chest compressions are started, we are going to compress for 60 seconds and then we are going to assess the heart rate. If the heart rate is more than 60, then we're going to stop compressions and we're going to continue with the positive pressure ventilation. But if there is no improvement, we need to check if we are giving proper bag and mask, if the FiO2 is 100%, whether the technique of compressions is correct or not. So this is the mnemonic cardio. If the heart rate is not improving, is the chest movement present? Is the airway secured with the ET tube? Are we following the proper sequence for the compressions and ventilation? Is the depth of the compressions correct? And are we giving 100% FiO2? So if all this is right, then the next things we need to rule out is it could be either because of hypovolemia or it can be because of tension pneumothorax. Some problems with compressions being there can be broken ribs, there can be lacerated liver, and there can be pneumothorax. So always focus where you're giving compressions. Do not go into the laterally sideways because it can injure the liver and it can lead to bleeding. The next step is medications. So if the heart rate is still below 60 in spite of the chest compressions, then we are going to go ahead with the adrenaline. And so this is after 30 seconds of PPV that inflates the lungs and 60 seconds of chest compressions with PPV using 100% of FiO2. So epinephrine is usually required whenever there is conditions of shock like vasoprevia, fetal-maternal hemorrhage, trauma, any problems with cord like cord disruption, tight nuchal cord compression, severe vaginal bleeding, or placental laceration. So concentration, we'll use the 1 mg per 10 ml. We need to dilute every day in the morning itself, 1 vial in 9 ml of NS. So the route preferred is IV or intraosseous. Endotracheal is to be used only before the IV is being established. And the flesh should be 3 ml. So these numbers are also recently updated. For the IV route, we are going to give 0.2 ml per kg or 0.02 mg per kg. For the ET tube, we are going to give 0.1 ml per kg or 0.1 mg per kg. And the bolus is 3 ml for both term babies and preterm babies. So the dose needs to be administered very quickly. It is preferred to give through UVC, followed by IV, followed by ET. So when given through ET, we need to give proper bag and mask so that it gets goes into the lungs. So whenever we are giving adrenaline, it is better to start preparing for the UVC access. So clean the baby, secure a thread, put a UVC, and do not insert the UVC like normally what we do. We should insert only up to 4 centimeters or so till we get the backflow. That is because if it goes into too deep, we cannot assure if it is going into the IVC or if it is going into the liver. If it goes into the liver, again, the dose is going to be ineffective. So just in neonatal resuscitation, we need to insert the UVC only till 4 to 5 centimeters. So the response to epinephrine is assessed again with heart rate, which is assessed after 1 minute after giving epinephrine. And if the heart rate is still less than 60, then we need to repeat the dose at 3 to 5 minutes interval. If you started at a lower dose, like if you started at 0.2 ml per kg, you can increase it to 0.3 ml per kg, but do not increase more than the maximum recommended value. So if you are giving it to ET route, then try to give through the UVC route. If the baby is still not responding in spite of the adrenaline, then we need to suspect that there is hypovolemia. And in that case, we need to give NS at 10 to 20 ml per kg. So it should be usually given fast, rapid bolus, but in babies less than 32 weeks, we need to give it over 5 to 10 minutes to prevent IVH, to avoid IVH. So some changes in the 8th edition, which we already discussed. So one is the doses have been changed to the adrenaline dose IV is 0.2 ml per kg, the ET one is 1 ml per kg, the bolus is 3 ml of NS after the adrenaline dose. These are the ones which have changed. Then coming to preterm resuscitation. So why do preterms require more support? It is obvious because the preterms have problem initiating respiratory effort. They have immature lungs. They do not have surfactant. The temperature maintenance is difficult, and they have immature blood vessels. This is the preterm temperature bundle. So for the temperature maintenance in preterms, in addition to what we give in the term babies, we need to compulsory use the exothermic mattress, plastic bag, wrap, humidified gases, warm fluids. Room temperature to be maintained at 23 to 25. And transport to the NICU needs to be done in an incubator. And coming to the preterm respiratory bundle, we need to give humidified gases, compulsory CPAP support, the inflation pressures, PIP needs to be low, surfactant has to be administered. Avoid excessive PIP and PEEP to avoid BPD. Avoid rapid ventilation to avoid hypocapnia. Give blended oxygen, 21 to 30%. Gentle handling. Avoid head low and rapid boluses to prevent IVH. So this we already discussed. Now coming to the babies born through meconium-stained amniotic fluid. If the babies are born through meconium-stained amniotic fluid and they are non-vigorous and with evidence of airway obstruction, then only we need to give intubation and tracheal suction. But for non-vigorous babies who are presented with apnea or ineffective breathing effort, we can go ahead directly with PPV. Laryngoscopy is not recommended. So if there is good respiratory efforts, good tone, the baby can just stay with the mother and receive the initial steps. We can use just a bulb syringe to clear the meconium-stained fluid. If the baby is non-vigorous, we'll first shift the baby to the warmer, give the initial steps, then start with PPV. And if the PPV is not causing adequate chest rise, if you feel there is some obstruction, then we go ahead with intubation with tracheal suction. Now, recommendations regarding withholding and discontinuing resuscitation. So in newborn babies requiring resuscitation, if there is no heart rate, we have performed all the steps. Then cessation of the resuscitation should be done after giving 20 minutes of resuscitation. Earlier, this was 10 minutes, which is changed to 20 minutes. And for any babies with asphyxia who are born more than 36 weeks of gestational age with evidence of moderate to severe HIE, we need to offer therapeutic hypothermia. If the baby required PPV for more than 2 minutes or required other advanced resuscitation like intubation, chest compressions, epinephrine, we need to transfer to the NICU and monitor. And always do GR-based monitoring during the NRP. And for newly born infants who are unintentionally hypothermic, less than 36, it is reasonable to warm the baby, either rapidly or slowly. To summarize, so newborn resuscitation is mainly because of respiratory failure in contrast to the adult failure, which is because of cardiac. So in newborns, we go ahead with TABC, whereas in adults, it is CAB. The most important and effective step in neonatal resuscitation is to ventilate the baby's lungs. Very few babies, like less than 1% of babies, only require chest compressions and medications. So giving proper PPV is the main step of the neonatal resuscitation. And closed loop communication and teamwork play a vital role. Thank you.
Amma, Dr. Pranitha Reddy.
Yes, sir.
Very good presentation, Amma.
Thank you, sir.
Very good, excellent. All slides are very beautiful. And regarding premature term babies, meconium is tested the word. Very good, Amma.
Thank you so much, sir.
Continue, keep it your career high. Very good. I wish you all the best.
Thank you so much, sir.
Thank you, Ma. Thank you, Ma. Thank you.